Hi, good evening,
Evening, everyone.
everyone. We're so glad to have you here and to join us again tonight on a Wednesday night. And so far, the last few days have been absolutely phenomenal. We've talked about the science and the medicines dealing with thyroid eye disease. And then last night, we started talking about how to have those conversations when you are diagnosed with thyroid eye disease and also writing your new story. Well, tonight we're going to get into what the research says, and a little later we'll be talking about taking charge of your life with quality of life. So we're going to go ahead and kick it off with our first three panelists that we have that are joining us. And very briefly, I would like for each of them to introduce themselves.
All right. I am Jody Abrams. I am an ophthalmologist in Sarasota, Florida, practicing neuro-ophthalmology and orbital surgery. So deal with thyroid eye disease quite a bit, and it's one of the most amazing things to help patients with.
Thank you. And next.
I'm Ira Lesser. I'm a psychiatrist, the past chair of psychiatry at Harbor UCLA Medical Center in Torrance, California. I've been a close colleague of Terry Smith for many years and got involved in dealing with patients through Terry.
Thank you. And last and certainly not least,
Hey there, good to see you again. Dr. Kimberly Cockram. I'm located in San Diego, and I really love the challenge of helping patients through their journey with TED. I'm also an oculoplastic surgeon, orbital specialist, and neuro-ophthalmologist, and just really pleased to be part of this program and great to see you virtually. Thanks.
thank you. As you can see, we have three dynamic individuals that are here for us to unpack talking about the science. And my name is Julie Owens, and I am a TED patient, and I will be facilitating this first hour. So we're going to go ahead and jump in with a few questions, and some of them I will put out directly to each of you. And then also at some point, I would like for the three of you to chime in on some questions that I put out. But the first question I'm going to put out, and since tonight is this first session is about research, what has the most recent studies revealed about how thyroid eye disease specifically impacts quality of life? And I'm first going to address that to Dr. Abrams and then Dr. Corcoran, if you can chime in afterwards.
I think we're starting to see a lot more of the research talking about the significant depression, anxiety, the really impacts that patients. I don't think a lot of us were talking to our patients or maybe asking the right questions about, and I think it's helping us guide that to bring open those discussions. Possibly before we were more worried about what the eye looked like, what the vision was, but now I think, and I mean, I will give a lot of credit to Kim, as a lot of the articles early I think were hers, and we're seeing this now, that the quality of life and talking about how does it affect your social aspects of your life, your interactions with others, your ability to get on Zoom calls is something I've learned a lot from patients that really kind of changed affected them. So as a physician, I think it's opened up my, world of talking with it. And I think that's been a big help and impact of the research coming out to knowing that we need to talk more.
Absolutely, absolutely. Dr. Corkerman?
I had the pleasure of seeing you guys in live at the American Academy of Ophthalmology, where we talked about this at length. And yeah, I think dating back to the 90s, when I was first caring for patients, it was very clear that the emotional impact was huge. And it's improved somewhat, but I think being that this is a disease where women are affected more than men, I saw many patients being told, you're just getting older, you're overreacting, when they had really significant impact on their life. So this has been an interest, that the whole emotional impact of thyroid eye disease on a person. And I personally had thyroid disease. So I lived not as severe as many of my patients, but having gone through that way back in the 90s, it gave me, personal, compassion for just the impact it can have on your professional life, on your personal life. So this has been an interest and passion of mine for many, many years, and happy to help ongoing.
Absolutely. And Dr. Lesser, I would like to bring you in on this since your specialty is psychiatry. I can imagine, and specifically with individuals with chronic illness, I can imagine that you have seen patients who are suffering from chronic illness and the things that Dr. Cockerman and Dr. Abrams have mentioned. You've definitely, I'm pretty sure, had to treat patients regards to that.
Yeah, absolutely. And I think the wonderful thing about what was said is that this is beginning to be seen more in the sort of the primary care or the neuro-ophthalmologist who see it rather than having to have a referral to a specialist, to a psychiatrist, because that often you should go see a psychiatrist is heard as an abandonment that I don't want to hear what you're talking about. So that for it to be dealt with by the people who are making the diagnosis and dealing with the eye disease, I think is wonderful. In the interest of sharing, I also have Graves' disease. I did not have any eye problems. That's how Terry and I sort of got friendly through that. But I did have some of the other manifestations, particularly the emotional ones of really just having highs or lows. And so I agree with Dr. Cockerham that it gives you another kind of empathy for the patient. Dealing with a chronic disease, very difficult, and there's lots of emotions, and we could talk about that as the hour progresses.
Definitely. And I'm almost certain, like mentioned before, you have seen a link between the visible changes that the patient is experiencing and the social withdrawal that they have.
Yeah, no question about it. And part of it is there's such a large range of emotion. A big part of it is the appearance, but also the uncertainty, the uncertainty of the future, the uncertainty to what extent this will affect my ability to have relationships, my ability to be in the workforce, my ability to be a parent or a mate. All of those things are so inextricably tied up with how we see ourselves and how we assume other people see us. And so it's really quite complicated and really needs a great deal of support as we could talk about as we go further.
Yes. And so I'm going to put this out there for all three of you. You mentioned about relationships, but how do you think TED impacts the family relationship and daily functioning?
I think that the brain fog that it creates, whether you're hypo and you feel fatigued, or you're hyper and you feel almost manic or panic attacky, but just the feeling like you can't make simple decisions, that dealing with more than one issue just explodes your brain. It just makes your brain full really early in the morning. And so I tell patients, like, make lists, try to give yourself space to make decisions, try to step back from, you might have been a gung-ho multitasker, and you just have to accept that for now, not forever, but for now, that's not going to be your new you. And so just giving yourself space to not get upset is super important.
And
I'm
some of
so
the
glad you said that. Oh, I'm sorry, Dr.
oh,
Abrams.
I was just, sorry, Joe. I was just going to say some of the things I've seen with the family environment is the patients will say, I might be able to go to that function, like go to the beach. Here in Florida, we have some of the most amazing beaches, but they don't want to go and enjoy it because their eyes might be irritated, be worse. They might have a lot of difficulty that day or going out to functions, dinners, to where they're more reserved and they're not as involved in the family life as they used to be. Going out to use sports or whatnot to watch the kids is something I've heard a couple times, and that's a big impact.
Yeah.
Definitely, it is a huge impact. And, briefly, that's something as a TED patient, I for sure have experienced where I've had those brain fog moments. And not being able to make quick choices like I used to, and then definitely socially withdrawing. And you hit it dead on the head, Dr. Abrams. And one of my girlfriends said to me, it's interesting how you may know next week, Wednesday, you might not be able to go to this meeting with me. And I said, listen, I have to give myself grace because I don't know how I'm going to feel next Wednesday. So thank you very much for that. Dr. Lesser, did you want to add to
No,
that?
I think the family aspect is so important because it does affect the family, and then the family member needs to sort of run a tightrope between encouraging the person to do things which they know in their best, it may be in their best interest, and being sensitive to the fears that the person has. And this can get into sort of a little bit of a tug of war, or rather in the way of trying to support somebody, it's felt as if it's a demand on the patient, and that can be very tricky to navigate.
Definitely, definitely. So we're going to shift just a little bit with the questioning. And what do either of you think is the most significant financial burden that patients will face because of the result of thyroid eye disease?
I would say the need to step back from job commitments
Mhm.
because of the brain fog, whatever form of employment they have typically is severely impacted, equally to the social impact of their friends and their family. And in trying to grasp that they do need to step back, do need to think about short-term disability, maybe long-term disability. I just had a patient in my office today, and she had quit her job, which was an excellent thing because the job was so incredibly stressful. She had loved it before, but it was definitely making her stressed out beyond what she should be stressed out each day. And so sometimes it's just taking a good look and saying, is this really the job for me now? It was for the job for me maybe then, but I need to think about my health and put my health above my work. And that's, I think, an equally difficult struggle as the family and friends problem.
Mhm. And I've had patients say they didn't go for certain promotions or advancements in their careers because it might involve being in front of groups and they didn't want to be there because they were worried about how they'd be viewed or if their eyes were going to irritate them that day or have problems with it. So they have been held back in their careers and and that's definitely affected them financially.
Definitely. Dr. Lesser, have you treated any patients who've come to that crossroad with that when it comes to employment?
I have not, and I think my colleagues are much more experienced about that than I have. I've not been in that situation.
That's definitely something for a conversation if patients are dealing with that. I know some that have TED, they've put in so many years and at their job, and they have contemplating that, you know what, maybe it is time for me to step back, maybe it's time for me to retire. And that can have a significant impact on your mental health because you've put your all in all in your career, and somewhat your career may even have even defined you, but here it is that you're looking at, you know what, I can't keep up, I'm not able to do this on a day-to-day basis, so maybe it's just time for me to bow out. And this is what a lot of others do not understand what TED patients are experiencing. And I thank all of you for sharing that. So now, um, talking about the quality of life, what impacts do you think differ between those patients that have some mild cases and those that may have severe cases?
I think it really depends on the patient because I've had patients with very, very severe proptosis that are not bothered. I had one woman who said to me, my mom looked like this. I this doesn't bother me. And so she was remarkably unaffected by her proptosis, but she didn't have pain. She didn't have double vision. She didn't have brain fog. And then you'll have other patients where they have relatively minor bulging and proptosis of their eye, yet they have severe pain or double vision, or their their life is around interacting with people, and now they're not able to perform at work, or they, you know, their interaction with their family and friends is severely impacted. So I think it's a super personal journey. I don't think you can look at somebody with thyroid eye disease and say, you're mild or you're severe. I think it's a matter of doctors asking, how has this impacted you? Because if it's severe, if it's severely impacting you, it's not for us as physicians to judge. And I remember back when I was in training, and I was had a patient that had a lot of concerns, but was not, you know, it didn't have very, you know, huge bulging. And I remember somebody saying, well, you know, she just needs to get used to it. And I was like, oh my gosh, that's not the message. The message is, what's it doing to your life personally, professionally, and how can we help you? And understanding each patient's needs and concerns are different.
Absolutely.
And I think it changes over time. Some patients maybe early on they are okay with it or deal with it, but over time it starts to wear down. And I've had patients that clinically didn't look like they changed, but all of a sudden we start to have that conversation. And while it was okay a couple years ago, now they're like, I'm done. I can't deal with this anymore. Some event occurred. And it's always, I kind of try to open with that question of how are things going? How's it impacting you? Not just what do I see on an exam or, you know, what the numbers might be at somewhere. But I think that's important to constantly ask because it does evolve without a doubt, even if the disease doesn't look like it's changed.
For sure.
And I think the opposite can occur as well, that it impacts people more at the beginning and they become more adaptive to it as time goes on. So I think that that highlights the variability that we
Mm.
talked about earlier. And the other thing is, you know, we all come to an event with past experience of resilience and how we dealt with adversity before. And that's so different for everybody. So somebody who might have thyroid eye disease, who's been through other traumas, may deal with it very differently than somebody who's not had a previous trauma. And so we really, you know, it's not, oh, it's mild or it's this many years. It's really that in the context of what the person's own story is and relationship in their family and their culture. And, you know, and in our culture of, you know, everything is magnified with social media, that makes things very difficult, particularly for the younger people.
You're so correct about that. It social media definitely has a huge influence and on individuals with chronic illness and the help that they are seeking. So talking about the differences in quality of life and the outcomes, um, what do you think the outcome could be? And this is for all three of you, between patients who may receive an early intervention and for those patients who don't receive any type of intervention.
That's a tough one because you have to weigh risk and benefit. And so, definitely, our goal is to find the safest possible early intervention with the least side effects and most efficacious outcomes. And that's the direction I see us moving now. You know, before there was limited things, right? Steroids had horrible side effects, radiation dried your eyes out, surgery, you know, can be scary for people. So now that there's so many different entities being or molecules being investigated, I'm hopeful we'll get to somewhere where when you start to have the very first symptoms, there's something safe and efficacious that can be implemented early on and prevent you from having to get to someplace that's bad. That would be amazing. You know, especially if it could impact not only the eyes, but the brain fog and the facial changes and all of it. So, I mean, I think we're closer than we've ever been, and that's super exciting. But we're not there yet, unfortunately.
But it's nice to keep getting these new tools in our belt. I mean, you and I have done this long enough that it was basically a hammer for years. And now this new medicine's coming out and research finally. It's uplifting to be able to tell a patient I might have something now or in the future to help you, where in the past it wasn't. And I think it's got to be tailored to each patient. Some patients early on, like Dr. Lesser said, maybe that's where you need to treat them earlier. And some people it takes a while to where you get to that. So this is a disease that I really find you have to sit and kind of tailor to each person individually.
Mm.
And I can't speak to the treatments like my colleagues can because I'm just not familiar with it. But both of you used a word that I think is so crucial, and that's instilling hope. Not false hope. Not everything's going to be okay. It'll be fine. That's invalidating to people. But the fact that, we can together work on this. And if this doesn't work, then we may be able to try something else. So just keeping the hope alive is and that I think helps combat the demoralization that people with TED or other chronic diseases have. They get demoralized. And if
Mm.
we can, in a therapeutic relationship, and I don't mean psychotherapy, I mean healthy with a healthcare provider, instill that hope. I'll be there. I'll be with you. We can try it. I think that's really very, very helpful for patients and their families.
It is so comforting as a TED patient to hear all three of you with, you're definitely giving the facts, but also on the end of that, you are speaking life and hope, and you're sharing that with your patients. On the other hand, I've been very, very fortunate throughout my TED diagnosis and my journey to have an excellent care team. And but there are many that have not experienced that. They have not. We in the after party, there are some patients that share their experiences, and I know one particular person shared that she had not had any conversations with her physician about thyroid eye disease. And I don't know where I would be right now if I had not had conversations with my care team about thyroid eye disease and getting the hope that comes along with the diagnosis. So all of you are talking patient language first, which is excellent. And you are you're along the journey with them. And you're definitely, like I said, you're giving the facts, but on the other end of that, you're giving hope. And you know that research has evolved, medicine has evolved, so many things have evolved. So there is definitely hope at the end of the day. And that is just so comforting to know. And I think those that are on and watching could probably say the same thing. So now let's opened up, started talking about a little bit of the data. Let's go back if you can share a little bit more. So how can the quality of life data, how can that influence treatment decisions?
Well, I think that we've changed the linguistics of thyroid eye disease discussions. We used to say active and chronic, or active and inactive. And what we know is that the quality of life across all spectrum is impacted. And so some of the data that's out there about, the chronic thyroid eye disease patients are just as unhappy as many of the recently onset. And so I think it's good to, when I talk with my patients, I say, do you find this an inconvenience? Do you find this impactful, or do you find this completely disruptive? And that's a better language. It doesn't matter if you've had thyroid eye disease for 1 day or 10 years or 30 years. I think we as clinicians need to step in and look at options. Uh, if it's impactful or disruptive. If it's just inconvenient, then maybe, vitamin D, selenium, some supplements, some artificial tears are all you need. But if it's something more, then there needs to be a bigger discussion of how can we help this not impact you in the way that it's impacting you.
I like that. I
And
like that.
I agree. It's definitely the patients that have had it longer, more of the chronic long-term disease. We were kind of just set on, okay, you're doing okay, not asking the questions probably as well. And I think this quality of life showing that even patients that have had it 5, 10, 20 years have significant impact, but they maybe stop telling us. And that's something I think I've learned to start asking is, okay, let's just not hide it. Let's not say that's normal. Let's talk about it and see if this is an impact. And I like how Kim's saying, what level does it impact you, guiding the treatment? But it's important to kind of empower them to tell us, even though it's been there for long, and maybe they've been told by other physicians, hey, there's nothing they can do. You don't need treatments. You're not going blind, and just live with it. And I think that's keep the quality of life has really shown us that you need to keep pushing to get the answers out, or at least give them the opportunity to answer that.
That's great.
Yeah, I think another aspect that we haven't touched upon, and by this I don't mean to pathologize people, but everybody has a lot of emotional reactions to this, which are expected, normal, if you will. And then there'll be a certain percentage of people where it will almost morph into something more. And I think this is what Dr. Abrams may have been alluding to, that people who stop talking about it but have developed a depression over and above what might be seen, what you see every day. And I think we need to be sensitive to that because and not you know, not blame the patient, oh, now you're depressed, but, people with chronic illness have high rates of depression, and the depression often gets in the way of them continuing on treatment for whatever the disease is. So I think an index of suspicion as to has this gone into an anxiety disorder, has this gone into a depression independent of and over and above the eye disease, I think is worthwhile to keep in mind. And that then may develop into referral to a mental health clinician because the primary care person probably doesn't have the time and in many ways not the expertise to do it on an ongoing basis.
Wow, thank you. Definitely some nuggets to take away from that. And as Dr. Cockerman mentioned, I like that asking, okay, so is it impactful? How impactful is it? Is it disruptive? And is it convenient? And I definitely am going to keep those types of things in mind when I'm sharing with others and encouraging others who are still on this journey with us with thyroid eye disease. I thank you for that. Um, again, with research, what gaps do you think still exist in research when it comes to TED patients and the impact on TED patients?
I think that the last 5 years, dating back even to 10 years, have been the most exciting, amazing time for thyroid eye disease. I still remember being told that there's not enough people with thyroid eye disease, no companies are interested, nobody wants to help. And so when River Vision, back when started and then moved on to Horizon and then moved forward with teprotumumab, Tepezza, that just created this surge of interest. And so now there's just a slew of pharmaceutical companies interested using different molecules, blocking different things, getting super interested in inflammation and the fibrosis and all the different changes of thyroid eye disease. And I know Jody and I talked about it. I mean, it was amazing in the midst of the pandemic to realize that there was a medication that wasn't going to just take some of the inflammatory signs away, but literally was going to remodel the tissues. So take the eye muscles and fat and make them go back to normal in not only patients with recent onset, but patients with durations of diseases in the 10 to 20 years. I mean, it was a miracle. And the fact that then that sparked all this amazing research interest, I mean, I'm just very optimistic that not only thyroid eye disease, but a lot of autoimmune inflammatory things will get help by the new surge in research. But research takes time. And so the only molecule that I think will come to market in the near future is the Viridian molecule, which is an IGF-1 monoclonal antibody that blocks in a similar way to teprotumumab, but a lower dose with fewer infusions and then possibly injection. So I think that's the exciting thing we hope to see in 2026, 2027. Everything else is in progress, but not in a pipeline. I tell patients I don't see anything else coming forward in the very near future. But that could be exciting because it could change the way that we deliver the molecule, which the injection, could come out after that. But lesser doses, maybe less side effects. That would be awesome. Really amazing for patients.
Wow,
I
that
think
sounds very hopeful. Yeah, for sure.
it's been amazing. It really has changed everything we were taught. I mean, what we were taught about this disease 20 years ago or even 10 years ago is now kind of wrong. I mean, this whole curve of don't treat them later on and you can't help them has really opened up. And I think that's why we're seeing such an impact of different patients than the small numbers they originally were thought were going to be treated with the medications. And it's neat to have that research is going to come down. And I think we're not only seeing maybe new molecules, but also how to work with the current, teprotumumab and the new molecule, maybe different dosaging. Maybe we need to give it a little bit different ways. And I think that's going to help patients get a long-term effect and feel better and have less of that worry. I mean, I think, Julie, you had said one time you wake up every morning to look and see what your eyes are going to be. And that kind of stuck with me that it's a worry, is it going to come back? And maybe as we know more research, that's part of the data we need to look at is can we stop that fear or kind of get it to where it's not your daily wake up and you're more like, oh, it's going to be a beautiful day, not a what does my eyes look like when I look in the mirror right there. So I think that's where we're going to be going. And as we learn more about how this disease acts and how the molecules will work, we're going to be better at it. And that's amazing.
Yeah, and although it's not a gap because the gaps makes it sound like it hasn't been tried, but you need a couple of years of people being on these new molecules to really do exactly what Dr. Abrams said. Does it really change their perception of themselves and of their lives? That's the quality of life that you're, I think, talking about. And clearly it helps and it's miraculous. But what does it really do to somebody's view of themselves? And I think that's very interesting research and can only occur with, years of experience of the drug.
Definitely. And I mean, I'm excited just sitting here talking about that. And I know others that are listening, they're equally excited as well. So this is just marvelous. We're going to end with our last question, and I'm definitely going to be taking notes on this because this is something that is really near and dear to me. So if all three of you definitely can chime in. How can we, as TED patients, and myself as an advocate, and pretty much everyone that's on the call, um, use quality of life research to influence policy and care standards?
That is a fabulous question. So when the TEDS research studies started, the FDA literally said the quality of life tools were not validated and could not be a primary or secondary outcome measure, even though that's crucial, right? And the FDA loves quality of life tools. So it's been exciting to watch the evolution, the validation of the quality of life tools, the confirmation that, the government funding agencies, but then that will roll down to the insurers and how they provide uh, the drug and authorize the drugs. That the ability of us to move the quality of life tools has been huge, 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 huge. And I got to say, thank you to you and thank you to your community because by being advocates and being vocal and sharing your experiences, you guys are going to make huge political changes. because we're in a country where the insurance companies control what our relationship is, right? So I want you to get this medication, but I have to go through your insurance company and get an authorization to help you get the drug I believe will make you happier and better and healthier and more productive. And that the more that we get patients, getting involved in this way in tools like this and other programs is just super important. And that's why, the quality of life, having this as one of your talks, I think it was brilliant. It's amazing because this is what we need to base these tools on for sure. But thank you so much for allowing me to participate in this today. And I'll go on to our other Jody or whoever's next.
I- Yeah, and I would just one of the big things for me is, I think it's important. This community is very involved. The people that are online, you're very involved with it. Tell other patients that you might meet, people that you see out there who might not be as involved, to get involved with the surveys, the quality of life research. So we have, I mean, one of the things that Kim and I did was 209 patients. If we can get 600 patients, that's even more powerful, and they're out there. And I think it's just encouraging patients, because the more data we can give, the more we can go to these insurance companies and say, hey, listen, it's not just the clinical findings. Here's so much an impact on the patient's life and their well-being that we can help treat with these different modalities. And it helps us know where to go as clinicians and what to ask and look at. So I think that's a big part that these studies are going to be need, and we need patients to participate in them and, get online and whatever else they're at, spread the word to do that.
And I think as patients and families do participate, it takes away a little of the helplessness that people often feel, that they do feel they're doing something. They're part of a community, they're part of an advocacy, and as changes get made, they see that their efforts are not futile. And again, so people can get purpose in being part of this. And I think advocacy from the patient population of families is really incredibly crucial for all diseases, particularly for those where, there's not huge numbers and already great funding. So I think it's a wonderful effort.
I just want to say thank you again to all three of you, Dr. Cockerman, Dr. Abrams, Dr. Lesser. I thoroughly enjoyed our conversation, and I really hope that those that are out there that are listening, I hope you gained a lot of information and you have some additional tools in your tool belt, where we can continue this work and this journey, and rewriting our stories with thyroid eye disease. Um, we're going to transition into Q&A, and I would like the facilitator that's transitioning for the Q&A to go ahead and introduce themselves and just go away with the questions.
Hello, everybody. My name is Prasanjit. I've been working with thyroid eye disease patients for about 3 years now, and I want to thank all the panelists for a great insight. So we have a few questions. So I'll start with this first one. So I'm a TED patient, have a successful career and family life, but I lost my self-confidence when my face changed. I don't know how to get this back. Any suggestions?
Kim?
Do you have a doctor that you have a relationship with? An oculoplastics, neuro-op, thyroid specialist?
I think that's the biggest thing, is find somebody who knows how to treat it, knows what you're going through, and can get you the best options to get you back to you.
Yeah, you need a partner. As we've been talking, it's a journey, and you need to have an endocrinologist and an eye specialist, ideally. In my area, it's very hard to get an endocrinologist, so it could be your primary care doctor, but getting a team, that's what you need.
And if I can, go ahead, Dr. Lesser.
No, go ahead, Julie.
And if I can add to that, as a TED patient who experienced exactly what you're asking about, when I look at my pictures from 3, 4, 5 years ago, I look like a totally different person today. Um, what really significantly helped me was an advocacy and a support group. I don't know where I would be without a support group. And the TEDCO we are patients that we come together and we encourage one another. And all of us have a story about that, about how our appearances have changed and we've leaned on one another. So that's definitely something to consider in addition to what the doctors have shared.
And although it's not easy to do, it's easy to say, our appearance, although it's crucial because that's what, our entry into the world, it doesn't define us. You're a successful person, that is as much defining you as your face. And so if you can, the disease should not be the defining part of the personality. It's a part of the personality, but all the other kinds of skills and attributes that someone has, they are as important as the appearances. Now that's harder to get to. I know, I'm not just saying just do that, but it's sort of in the realm of at some point some degree of acceptance and being kind to yourself about it may be helpful.
Awesome. Thank you guys. So this next question, I avoid cameras. I agree with what Dr. Lesser said about social media. My daughter's wedding is coming up. I am dreading the photo sessions. How do other TED patients deal with this? So this question is actually directed to you, Julie.
Whoa. Listen, um, I've been there and I'm still there. What I have done is I'm in the mirror and I practice my angles when it comes to taking photos, what angle I think what looks best. I have asked about, are there certain things that I could personally do to try to improve my appearance? I got very little feedback on that in regards to that, but nonetheless, I still give it a shot. And the wonderful thing that they have now is filters. I use a lot of filters, and I think filters are great, and it helps me tremendously. But I'm there as well with taking pictures. I just work on my angles.
Thank you, Julie. This next question, what kinds of factors are leading to poor quality of life in people who are past the active phase and are in chronic phase?
I mean, we're definitely seeing patients that just have chronic pain, chronic visual disturbances, for years of dealing with just an achiness and not sleeping well. As Kim said, that kind of brain fog that can go on for a long time. I think those are not just in the early phase, but can go on for years and years. And those are definitely affecting the quality of life of our patients in social functions, work functions, just in their daily lives.
And again, some number of those patients, not everybody, again, may be struggling with additional kinds of psychological challenges, challenges about, you know, related to TED and not related to TED. And so being open to having, a consultation about counseling, and are there other, sort of counseling techniques that they could learn, mindfulness, meditation, there's a whole host of things that people with chronic diseases can engage in, both online. There are many apps. You got to be careful about that, or in a relationship with a therapist, so that should be considered. Lots of stigma, lots of shame about that, but if people can get over that, that can be very helpful as well.
I think it points out this is not a disease that's just an ophthalmologist or an endocrinologist. This is a disease that needs so many different aspects. I mean, the mental health is something that we don't probably acknowledge enough. And I think Dr. Lesser is right. We need to, continue on all sides of that to embrace it and know that there's so many different facets that we need to treat.
Well, I think the point of support groups is huge because the everyone's sharing a similar experience, not exact same, but understanding the impact on their life and their family and their professional relationships. And so I think, support like groups like this is just so incredibly important.
Thank you guys. And kind of to piggyback off that a little bit, another question was, are there resources for patients to use that might be helpful to screen for depression? How do we know when to seek help?
Well, there are screening that is done in primary care. There's a sort of tool, if you will. There's a two-question kind of tool. I mean, it's very simplified, but you know, the idea, if you're going to have a depression, you have to have low mood or feeling blue, being down most of the time, most of the day for a couple of weeks. That's one screening question. And the second is, have you lost your ability to enjoy things? Do you not get pleasure in any kind of activities? And that's varied for different people. For some, it's activities, some it's grandkids, some it's sexual activity. It doesn't matter. But if you lost the ability, if either one of those is answered yes, then one can go further and look at things like appetite and sleep. And there's fairly simple questionnaires that take 5 minutes to do and are easily scored. And that can be done in primary care, and it can be done in anybody's waiting room. The key is if you're scoring high, what do you do about it? And that's when the discussion must take place or the referral must take place.
Got it. Thank you very much for that. This question is kind of earlier on the discussion. Is the brain fog related to associated thyroid disease, or can it occur in people with TED who are euthyroid?
In my experience, it can happen in either. So it can be hyperthyroid, hypothyroid, just thyroid eye disease. I do neuro-ophthalmology, so it happens in other autoimmune conditions too. But it's definitely a change in cognition where people can't multitask as much. They get forgetful. Women experience it after childbirth and when they're perimenopausal. It's very similar. Um, and there's no specific evidence as to the mechanism of action or why. It was very interesting when Tepezza hit the market was how many patients had felt like their cognitive abilities were improved by the Tepezza. So not only was it remodeling the muscles, shrinking the fat, restoring their facial structures, but they felt like they could concentrate better, they could be more themselves cognitively. So the more we have seen with Tepezza and IGF-1 blockers, it's very interesting. So IGF-1 receptors are everywhere. They're in our brain, they're in our ears, they're throughout our body. And so when you block them and you allow a change to occur, there's all sorts of impacts. And so I don't think we understand this fully yet, is the role of the TSH receptor and IGF-1 in brain function.
Okay, and then another one. What are some suggestions for light sensitivity? This is a huge struggle for me.
I think one of the big things is make sure the surface of your eyes, dry eyes, definitely even mild dry eyes can cause a lot of light sensitivity. So hydration, talking to your doctor, their ointments or different drops that you can use. If you need to wear a mask at night to keep your eyes from getting exposed, very common thing. I use some blue filter glasses sometimes will help with our patients, or even kind of the yellow tint they'll find better. Um, Lowering blue light a little bit will help. I think on your iPhone, you can turn that down, and that seems to be a little bit easier on patients to get through. And those are, some of the ways that we'll deal with it with patients outside of just, if they need to wear sunglasses outside.
All right, thank you for that, Doc. And then Have your patients told you about the impact of thyroid eye disease on things like sleeping or driving? And as Julie said, data, is there data to show this is common among people with thyroid eye disease?
Super
Yeah.
common. Super common. So when you have hyperthyroidism, you lie down and you try to go to sleep, your heart is pulsing so much you can kind of hear it in your brain, you know. I mean, so you're just very impacted in a way that prevents you from falling asleep.
Mm.
And so that makes sense to me because you're revved up. But also patients with hypothyroidism complain that they can go to sleep, but then they wake up early and they don't get a full 8 hours of sleep. So again, the thyroid hormone is just a very important hormone in our ability to sleep and sleep well. And so however you're impacted, it can disrupt things. So it's not specific to thyroid eye disease, it's more specific to thyroid imbalance.
And the driving definitely can be impacted. I mean, if you have brain fog, you're not able to adapt to things occurring or feel it's comfortable behind the wheel. If you can't see clearly, thyroid eye disease definitely causes, I mean, double vision, blurred vision, all kinds of, the light sensitivity you just talked about. If you're outside in either California or Florida, it's hard to drive during the summer when it's so bright. And you might be squinting and not see well. So, and not driving is a big impact on life. So I think it all goes together. And or if you're tired and not sleeping, that can impact you. We all know that one too.
And I think we have time for one more. Are any of the doctors working with any of their patients to track the impact of thyroid eye disease on certain aspects of quality of life over time?
So all the clinical trials are currently using quality of life assessment, and that is the most controlled assessment I've seen. So whether it was Horizon, that's now Amgen, or Viridian, or any of the other companies, they are tracking quality of life. So the subjects do something at baseline, and they do it over the course of the trial. As a result, many, many more clinicians who probably never did a quality of life tool before are now implementing those in their own clinics with their non-research patients. And so it's going to be very interesting to see the papers and the assessments that come out, looking at patients who are not in clinical trials and how those same clinical quality of life tools are being utilized in private practice or universities or other settings.
Okay. Thank you so much, Dr. Cockrum. And we have another one. I just read from the thyroid eye disease research information about how the COVID vaccine may impact your situation with thyroid eye disease. Can you confirm this and what concerns should I consider?
So whether it's a vaccine or a virus, whether it's COVID or some other viral infection or virus protection through vaccination, we know that autoimmune diseases can be upregulated when you are exposed to viruses or vaccines. So during COVID, yes, there were patients who had reactivations or exacerbations of their thyroid eye disease, either having been exposed to COVID, been sick with COVID, or vaccinated against COVID. So that's well documented.
Okay. Thank you guys so much for the insight and the information.
There you go.
This was fun, you guys. I'm glad we're all doing it. Great to see you. Nice to see you, Jody, even virtually.
Yep.
Dr. Lesser.
Great.
Thank
Thank
you,
you all for
Julie, for putting this
joining.
Julie,
together.
Thank you,
yeah.
guys.
Thank you. I thank you. You will be hearing more from me. Thank you so much. And we
Bye-bye.
want to
Okay.
thank all of you that are with us. Hold tight. We have our next session that's coming up, and we will start shortly.